Hello, everybody. How are you doing today? Thank you so much for joining us. Our webinar today is entitled How to Mitigate Breast Cancer Risks, and our guest speaker is none other than Dr. Pamela Smith. My name is Dr. Lenore Powell, and I am a medical education specialist in Genova's Atlanta branch, and I will serve as your moderator for today's webinar. We'd like to welcome Dr. Pamela Smith. She spent her first 20 years of practice as an emergency room physician with the Detroit Medical Center, and then the next 20 years as an anti-aging functional medicine specialist. She is a diplomat of the board of the American Academy of Anti-Aging Physicians and is an internationally known speaker and author on the subject of metabolic anti-aging and personalized medicine. She also holds a master's in public health degree along with a master's degree in metabolic and nutritional medicine. She has been featured on CNN, PBS, and many other television networks, has been interviewed in numerous consumer magazines, and has hosted 2 of her own radio shows. She is a regular contributor for the Fox News Radio. Dr. Smith was furthermore one of the featured physicians on the PBS series, The Embrace of Aging, as well as the online medical series, Awakening from Alzheimer's and Regain Your Brain. Dr. Pamela Smith is currently director of the Center for Personalized Medicine and the founder of the Fellowship in Anti-Aging, Regenerative, and Functional Medicine. Dr. Smith is also the co-director of the Master's Program in Metabolic and Nutritional Medicine at the Morrissey College of Medicine, University of South Florida. In addition, she is the Director of Medical Education for the American Academy of Anti-Aging Medicine. She is the author of the best-selling books, HRT, The Answers, Vitamins Hype or Hope, Demystifying Weight Loss, What You Must Know About Vitamins, Minerals, Herbs, and More, What You Must Know About Women's Hormones, Why Can't You Lose Weight, and What You Must Know About Memory Loss and How You Can Stop It, What You Must Know About Thyroid Disorders, and What You Must Know About Allergy Relief, of which she is the co-author. So my next question would be, Dr. Smith, when do you sleep? In addition, you will have access to the presentation and slide deck on our website within a few days after the webinar. You can access these resources, previous webinar recordings, brief video modules, and other materials by clicking the Clinicians tab on the home page. And as everybody is well aware, due to the increase in these non-acute patient appointments through telemedicine, I just want to remind you, we do have many non-invasive tests, urine, saliva, blood spot, and stool collection packs that can be shipped directly to the patient for specimen collection at home, and the requisition can also be completed online. For more information, just visit your LiveGDX account. So I'm going to pass over the role of presenter to Dr. Smith, but seriously, when do you sleep?
Actually, I have very good melatonin levels, which is a wonderful thing. So I am a high energy soul, but I really do work on cortisol. I'm very serious about that, as we're going to see in today's seminar, because it's hugely important. So in honor of Breast Awareness or Breast Cancer Awareness Month, we're looking at this seminar with Genova and really how to mitigate breast cancer risk. I don't say this lightly. I have a lot of breast cancer in my family. On my mother's side of my family, I had an aunt who had breast cancer and she died of it. I had another aunt who had breast cancer and did not die of it. She's still with us at the age of 94. But they both had risk factors that they drank alcohol, which is a risk factor for breast cancer. On my other side of the family, on my dad's, I never got to meet my grandmother. She died of breast cancer during World War II, so I never met her. And then I have a cousin on that side, my only cousin who never married and had children, which is also a risk factor, died of breast cancer at 51. So I do have very much a personal interest in this topic. The incidence of breast cancer is on the rise. And I'd like to thank everyone for helping me put all this together, because it really was a labor of love with Dr. Chapman, Dr. Powell, and myself. Learning objectives, we're going to look at estrogen breakdown, the role of stress, the role of sugar, the role of melatonin, and how about methylation. So let's start with breast cancer itself. An increasing body of evidence indicates that breast cancer is the most common malignancy among women, representing 23% of all diagnosed cancer cases and the second leading cause of cancer deaths among women worldwide. By the way, it is on the rise in men. When I first started practicing, breast cancer in men was 1% of the breast cancer. It is now 3% of the breast cancer. Well, some of this has to do with estrogen breakdown. There is an individual variation in estrogen metabolization that can influence the risk of breast cancer and can provide clues to the carcinogenesis of breast cancer. And studies have shown that more extensive 2-hydroxylation of the parent estrogens is associated with a lower risk. Less extensive methylation of potentially genotoxic 4-hydroxy pathway catechols is associated with a higher risk of postmenopausal breast cancer. So the way I explain it to my patients is the 2-hydroxy goes into 2-methoxy. That's the good one. The 4-hydroxy estrogen, you don't want a lot of that one. And this is an abstract that was actually quite interesting. Estrogens are eliminated from the body by metabolic conversion to estrogenically inactive metabolites that are excreted in the urine or feces. The first step of the pathway is the hydroxylation, which is catalyzed by the cytochrome P450 system. The isoforms are abundantly expressed in the liver, and the metabolization of estrogen occurs mostly in the liver. By the way, there is still some metabolization in the gut. A major metabolite of estradiol, the 2-hydroxy, is mainly catalyzed by the CYP1A2 and CYP3A4 in the liver, and the CYP1A1 in the extrahepatic tissues. The CYP1B1, which is highly expressed in estrogen target cells, mammary, ovarian, and uterine, specifically catalyzes the 4-hydroxylation of estradiol. So since 4-hydroxy estradiol generates free radicals from the reductive oxidative cycling with the corresponding semiquinone and quinone forms, which can cause cellular damage, the specific and local formation of 4-hydroxy estradiol is important for breast and endometrial carcinogenesis. Changes in the expression levels of estrogen metabolizing CYP isoforms not only alter the intensity of the action of estrogen, but also alter the profile of its physiological effects in the liver and in the target tissues. So many CYP isoforms are induced by the substrates themselves, resulting in enhanced metabolization and elimination from the body. The CYP1B1 is regulated by estradiol via the estrogen receptor. So I put this in here because I do get a little bit of pushback from other clinicians saying that this is quote unquote voodoo medicine. Nobody looks at this. But you can see from cancer research, etc., that we do look at estrogen breakdown. There's many ways to look at hormone samples, from serum to saliva to urine. We could spend a whole hour talking on that. But when we look at serum, there are metabolites to look at. Saliva, no metabolites. In the urine, there's a broader approach. It reflects the combination of both excess endocrine production and the peripheral production of conjugated hormones and metabolites. So we like a little bit broader approach. And so we can do a complete hormone 24-hour test, which we're going to examine today, which I really love. You can do the first morning urine, which would be appropriate for people not on hormones. But if someone is on hormones, then I do like to do the 24-hour complete hormone study. The sex hormone metabolites, the urine testing provides a very comprehensive look. And emerging research does reinforce the potential relationship of disease risk with the downstream metabolites. So when do I look at this? If someone's new to me and they have a family history like mine, I look at it right away. So sometimes I look at it before they're on hormones. I look on it afterwards. Do be aware that for women, their metabolization of hormones does change with menopause. It does change when they deliver. So it doesn't stay the same throughout their lifetime. It's part of the reason why we want to continuously reevaluate the patient. When the urine shows unbound hormones and circulating metabolites. So when you look at hormone metabolization, it does provide an average of the hormone fluctuations. It assesses steroid enzyme activity, and it looks basically at the last 48 hours of hormonal fluxes, because people always ask, is it just a snapshot in time? So it's really looking at the last 48 hours. So it assesses the clinical management of hormone-related conditions. And as I said, we like to do the 24-hour one if the patient's on hormones already. If not, then we can do the first morning, but the 24 hours is always best. We're going to look at the CYP1B1, the CYP1A1, CYP3A4, and the COMT pathway. So when you look at the CYP1B1 pathway, you have estrone going into the 4-hydroxy form, into the catechol estrogen quinones. And higher levels of the 4-hydroxy can give rise to higher levels of carcinogenic quinones. These generate unstable adducts of adenine and guanine, and point mutations can then occur. So this is an example of excessive 4-hydroxy production. As I tell my patients, it's the bad one. You can see how the CYP1B1 pathway is part of this. When you look at treatment considerations, there are things that you can do to help the patient. There's things that people should avoid if they have an upregulation of the 1B1 pathway. So are PCBs a problem? They are. Are polycyclic aromatic hydrocarbons a problem? They are. There's a potential for treatment with hops, bioflavonoids, and grapefruit. I'm glad that my personal test did not have a problem in this pathway, because hops and I don't get along, and I hate grapefruit. But you get the point, right? We can do something to help these patients. So when you look at it, you can also do a SNP add-on. This is an add-on to the test where you can literally look at the genomics, and you can see the variants that are clinically associated with an increased risk in the different cancers. So I love being able to add this on, and particularly in someone with my family history, you do want to look at the genomics as well. So proposed mechanisms for cancer initiation are going through this pathway and then into error coding that occurs, mutations, and cancer. When you look at the CYP1A1 and 3A4 pathways, higher 2-hydroxy to 16 ratios in males have been associated with an increased risk of prostate cancer. And there's an upregulation of these pathways. So I do estrogen breakdown in men as well. I realize we're talking about breast health today, but men do make estrogens. They make all three. Men need a small amount of estrogen for their bone structure and memory. Too much increases the risk of heart disease and prostate cancer. So I do this test on both my male and female patients. So when you look at the CYP1A1 and 3A4 pathways, this is an example of normal pattern. So are there things you can do? Of course. Cruciferous vegetables, berries, I love berries. Indole 3-carbinol, its breakdown product, DIM, soy, flaxseed, caffeine, rosemary, exercising, and if the patient is hypothyroid, thyroxine has been shown to help at the 1A1 pathway. What makes it worse? Sugar, okay, cimetidine, oral contraceptives. There are some things that make that worse. The same thing when you're looking at the 3A4. and the 2-hydroxy into the 16. Hypothyroidism, pesticide exposure, smoking, caffeine, various issues make it worse. What helps? Grapefruit, peppermint oil, rosemary, wild yams, antifungal agents if needed. And there are nutrients, by the way, that you can use for antifungal. It doesn't necessarily mean that you have to have diflucan or nystatin. When looking at the COMT pathways, these are important conjugation pathways for hydroxylated estrogens, and the pathway can be compromised in a patient with a COMT SNP. So examples of poor methylation, poor conversion from 2-hydroxy to the 2-methoxy, and a high 2-hydroxy to 2-methoxy is the scenario you want. So, or the high 2-methoxy, you want more methoxy and less of the hydroxy. So you want the improved pathway. So how do you raise the 2-hydroxy estrogen so that it's more than the 4-hydroxy? And how do you make sure that it's methylated appropriately so you have more of the methylated components? Well, raising 2-hydroxy estrogen, moderate exercise, cruciferous vegetables, flax, kudzu, broccoli derivatives, its breakdown products, I3C, DIM, and sulforaphane, omega-3 fatty acids, nutrients that support methylation, rosemary, turmeric, weight loss, high protein diet, and reducing catecholamine production. Other factors that affect estrogen metabolization, obesity. Obesity decreases the 2-hydroxy and increases the 16. You need a little bit of 16 for bone structure. Too much increases the risk of disease. Estrogen is stored in fat cells. So that's another thing that is a reason that obesity affects estrogen breakdown. And then, of course, there's environmental estrogens. There's over 50 chemicals that imitate estrogen that are toxic to the body, and all the way from synthetic hormones fed to animals, plastics, cosmetics, and pesticides. Very important. The CDC has now come out and recommended that women do not drink alcohol at all. Zero. Zip. And if you ask me, am I a teetotaler? I am. Women metabolize estrogen slower than men, and unfortunately, it increases our risk of breast cancer. Alcohol interferes with the body's ability to detoxify estrogen and increases E2 levels. Antibiotics that are found in foods can be associated with an elevated risk, so eating organic is really important. A key enzyme involved in the deactivation of catechol compounds is important to look at as well. So we can look at the enzymatic activity for people because we also look at mood imbalances, chronic pain syndromes, elevated stress. So we can look at these pathways. You want to see 2 of those green negative bars. That's normal COMT activity. Moderately decreased, you will see in the middle there and at the bottom, these are people that come back with the red plus sign and the downward blue arrow, substantially decreased COMT activity. So these pathways, COMT, support methylation. How do you do that? Magnesium. Magnesium is a cofactor for over 100 reactions in the body. B vitamins, folic acid. Some people do need methotetrahydrofolate. I happen to be a poor methylator, and I've been fortunate enough to have learned all this 29 years ago. So I have been taking methotetrahydrofolate, BID, for 29 years. So it's no big surprise then that I have a family history of breast cancer and heart disease. You can use trimethylglycine, SAMe, methionine, and stress management. Those things support methylation. We are going to talk a little bit more about methylation as we go on as well. How about stress? Honestly, stress, it's a risk factor for almost anything that you can think of. Cortisol is the only hormone in the body that increases with age. It's made by the adrenals. And with COVID and this crazy 365, 24/7 society, Dr. Powell was razzing me about never sleeping. Honestly, I do sleep. I'm a really good power sleeper. When my head hits the pillow, I'm out, because that helps normalize my cortisol. So if you go back and look at all my tests over the years, my morning cortisol has always been normal. If you wake up with a high cortisol in the morning, it means that you or your patient did not get restorative sleep. I love this poem by Carl Sandburg. Time is the coin of your life. It is the only coin you have. Only you can determine how it will be spent. Be careful lest you let other people spend it for you. So it's hard when you're a practitioner, you're a pharmacist, etc. Other people do seem to want more of your time. So cortisol has a lot of functions. It's really important for the immune system. It doesn't matter if you're talking about prevention of breast cancer or if you're talking about COVID. Everybody gets cancer 4 or 5 times, maybe 8 or 9 times in their lifetime. There's 2 things that feed cancer cells: stress and sugar. And obviously, if you have a compromised immune system, it's an issue. Cortisol is so important for your immune system. It also improves sleep. It balances the other hormones, has to do with protein synthesis, mood, regulates blood sugar, regulates weight. It is part of the immune system and influences bone turnover. So if you're stressed long-term, it does drive up cortisol, as does depression and high progestin intake and high prolactin, inflammation and obesity. When the patient's overweight, it is an inflammatory state. So when the patient's first stressed, cortisol elevates. When they stay stressed a long time, the body only makes enough cortisol to keep it alive. So what lowers that cortisol? Chronic stress, Addison's, opioid use has become a more common reason. Chronic marijuana use has as well. Accutane and long-term steroid use. One study suggested that as many as 75 to 90% of visits to primary care doctors are stress-related. Another study, chronic stress has been shown to contribute to accelerated aging and premature death in medical studies. Another one, it really changed the telomeres as well. So what are consequences of elevated cortisol? Does it compromise the immune system, and how does it do it? It decreases the release of antibodies. It causes an inhibition in the proliferation of T cells. It increases inflammatory cytokine production. It inhibits the release of some interleukins. You have latent virus activation, a shift from Th1 to Th2 expression, and an increase in infections. That all happens in just looking at the immune system if you stay stressed. Also, cortisol increases the risk of developing bone loss. If you stay stressed, you get fatigue, irritability, sugar cravings, hypertension, an increase in blood sugar, insulin resistance, and diabetes. And if you stay stressed, or your patient does, an impaired hepatic conversion of T4 to T3. Oh my gosh, there's a whole nother page. Other consequences of elevated cortisol: binge eating, confusion, shakiness between meals, memory is not as sharp, cholesterol, blood sugar, triglycerides all rise, night sweats, thin skin, easy bruising, muscle weakness, weight gain around the middle, sleep disturbances, and it does favor the development of leaky gut syndrome if the patient stays stressed. So abnormal cortisol levels are associated with all of these things in the medical literature, and you see right there is breast cancer. So it's important to look at saliva testing. I really do these all the time, and I love getting the 4-point cortisol. Morning, noon, afternoon, and evening. It gives me so much more information as to really what is causing stress with the patient. The cortisol does have a companion hormone from the adrenals. It's DHEA, and I love the adrenal cortex stress profile, really looking at both of these because it is a ratio between the two. So what do you do for patients that have too much cortisol or too little? You start with the same thing: stress reduction techniques, prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques. What else? Acupuncture. It does take nutrients to run the adrenals. So I do have people start a multivitamin. Make sure if DHEA is low and you give DHEA, that you also give adrenal support, like calming herbs and adaptogenic herbs. If you give DHEA and cortisol is not normal, it's too high or too low, and you don't address that, if you just give DHEA by itself, when you go back and remeasure, the DHEA levels are actually lower, even though you're giving DHEA. I love rhodiola, ginseng, ashwagandha. If cortisol is high in the evening, then adding phosphatidylserine at 300 milligrams anytime during the day can be beneficial. For low cortisol, you start with the same things. If that doesn't work after about 9 months, you can take the patient off of the looking at adaptogenic herbs and put them on adrenal extracts. They are purified. If there's still a problem with low cortisol, you can add the herb licorice, not the candy, the herb. Don't give it to people with hypertension. If the patient develops hypertension on licorice, then take them off. The last thing is Cortef. Please do not start with Cortef. It is malpractice to do that. The medical board will not like you, and you can hurt the patient. Cortef is to be dosed for 6 to 9 months. I do leave people on extracts where they're on Cortef, so when I'm weaning them off of Cortef, the extracts are there for them. Sugar. This used to be my biggest issue personally that I wasn't very good at. I really am a teetotaler, so for me, that is not my source of sugar. Unfortunately, chocolate used to be. I really have come a long ways. You have to meet the patient where they are. Nobody's perfect. Nobody eats perfect, drinks perfect, but sugar intake at a high level does increase the risk of breast cancer. Many major authors have examined the relationship between cancer and high sugar intake. I've had the privilege of knowing Nancy Appleton. She passed away last December. She wrote Suicide by Sugar, Lick the Sugar Habit. She really is a PhD that opened my eyes to the fact that high sugar intake is not a wise decision. Older women, a strong correlation was found between breast cancer mortality and sugar consumption in a medical trial as well. If you look at epidemiological studies from 2016, dietary sugar intake has a significant impact on the development of breast cancer. One proposed mechanism of how sugar impacts cancer development is inflammation. So that should be no surprise. Another increases the risk of breast cancer with high sugar ingestion, shows that dietary sugar induces 12-LOX signaling to increase the risk of breast cancer development and metastases. Specific types of cancer like triple negative are both responsive to dietary factors and exceptionally difficult to treat, illustrating the fact that prevention is always the best way to go. And this 2019 study showed a link between increased dietary fructose consumption, development of metabolic disturbances, and an increased incidence of triple negative breast cancer. So I really do try and stay away from fructose. Alcohol, there's a lot of studies now on alcohol intake. It is associated with an increased risk in breast cancer. Further, we're looking at this increased levels of endogenous estrogens, which are known risk factors for breast cancer, occur when that patient imbibes. This hypothesis is further supported by data looking at alcohol breast cancer association is limited to women with estrogen receptor positive tumors. In fact, the products of alcohol metabolism are known to be toxic and are hypothesized to cause DNA mutations that lead to cancer. And recent research has focused on genes that influence the rate of alcohol metabolization, which genes that rise the blood concentrations of acetaldehyde. This is hypothesized to increase the risk of breast cancer. Looking further, mounting evidence suggests that antioxidant intake, like folate, may reduce the alcohol-associated breast cancer risk. But remember, when the patient drinks alcohol, they get depleted in B vitamins. So this is important to look at. It neutralizes the reactive oxygen species, a second stage product of alcohol metabolization. So diets that lack sufficient antioxidant intake may further elevate the risk of breast cancer among women that consume alcohol. Another study looked at reactive oxygen species resulting from ethanol metabolization. Again, DNA damage. Some people say there are no studies. There are. It's looking at one carbon metabolization, how alcohol can negatively affect those folate levels in this trial as well. And from the American Cancer Society, drinking even small amounts of alcohol is linked with an increased risk of breast cancer in women. Alcohol, again, can raise estrogen. The amount of alcohol someone drinks over time, not the type of beverage, seems to be the important risk factor. Because my patients said, well, does it matter if it's a glass of wine or a beer? It's over time. It does not matter if the alcohol, in what form it is. Most evidence suggests that ethanol increases the risk. So the American Cancer Society has also come out and said, please, women, do not drink. Melatonin, does it affect breast cancer? It does. Melatonin, as you know, has many functions in the body. Number one is not sleep, it's aiding the immune system. In fact, we now treat stage 4 breast cancer with 20 milligrams of melatonin, with or without chemo. It's very fascinating to look at. I'd like to measure melatonin levels because if you give too much melatonin, serotonin goes down. But when we give melatonin to people with breast cancer and you measure, the levels of melatonin are not high, even at 20 milligrams, because the body has figured out that it's going to use it to prompt the immune system to try and kill that cancer. So now when women have stage 3 breast cancer, I give melatonin, and stage 2 and stage 1, I just give lower doses than the 20 milligrams suggested in the medical literature for stage 4. Melatonin is also an antioxidant. It blocks estrogen from binding to receptor sites. It decreases cortisol and balances the stress response. It helps to prevent cancers, improves mood, sleep, stimulates the parathyroid, so you do have to be careful with it if the patient has hyperparathyroidism. It stimulates the production of growth hormone, the hormone that keeps you young. Melatonin is heart protective, protects against reflux. It affects the release of sex hormones, lowers blood pressure, free radical scavenger, decreases inflammation. In studies, it actually can lower CRP and interleukin-6, inflammatory markers. It helps prevent and treat memory loss, and it aids in stroke prevention and treatment. So here's your references to all of that. So how do you have low melatonin? Actually, we're probably producing low right now because electromagnetic fields like cell phones, computer screens, this can lower melatonin. So unless my patient has an emergency, you honestly won't find me on my computer after 7 p.m. It's probably why I sleep so well. My melatonin is normal. The aging process can lower it, so can tobacco, drinking too much caffeine, too much alcohol, and too many high glycemic index carbs. So melatonin is used to prevent and treat all of these different things. I put a lot of references here for you today because a lot of people will say, oh, melatonin doesn't matter, but it does. Many studies have shown that melatonin is an effective therapy for breast cancer as an adjunct to traditional care. So I put a lot of references here for you on this as well. Symptoms of excess melatonin: you have the patient take too much, daytime sleepiness, fatigue, depression, headaches, an increase in cortisol, which can lead to fat storage, intense dreaming and nightmares, and again, suppression of serotonin. So the good news is you can measure melatonin. You don't have to guess. And the way I explain it to my patients, it's morning, 5 p.m. and 3 a.m. with the lights off. Make sure that you tell them the lights are off, put the tube by bedside, spit into it, then turn on the lights. And it should be dead center of green. Clinical tip: if melatonin's high in the morning and the patient's not on melatonin, that usually means the cortisol is not normal. Methylation in breast cancer. I thought we would come back to this, and we are. So think of methylation kind of like a spark plug. You can tell I'm from Detroit, right? It evokes the certain chemical reactions. So methylation helps convert serotonin into melatonin. It helps change strong estrogens to the milder, less aggressive estrogens. The disruption of normal methylation patterns has been found to be a very important event in carcinogenesis. And cancer initiation and progression is driven by the accumulation of inherited or acquired DNA mutations. So these alterations may be genetic or epigenetic in nature. Epigenetic modifications are changes in the DNA structure that do not involve sequence changes, but are inherited from cell to cell. These include DNA methylation, histone modifications like phosphorylations, acetylation, methylation, and microRNAs. Remember, if the patient doesn't methylate well, there's an increased risk in heart disease, stroke, bone loss, cognitive decline, and obviously cancer. So what are signs and symptoms of a poorly methylated patient? High histamine. Remember I told you I was a poor methylator? I've had high histamine since I was a kid. You can measure histamine. People can have histodelia. They're actually born with a gene with high histamine. People with OCD, history of perfectionism, ritualistic behaviors, very strong-willed people. They may be underweight, competitive in sports. They may have a calm demeanor, but they have high inner tension. They have a family history of overachieving, delusions, self-motivated during the school years. So the mother didn't have to say, or the father didn't have to say, hey, go do your homework. They do it themselves. Sparse body hair, social isolation. I hope you're thinking of your patients as I'm looking at this with you. Poor long-term concentration, addictive behavior, phobias, response to antihistamines. Patient may tear easily, high libido, seasonal allergies, long pain tolerance, frequent headaches, increased risk of developing major diseases, and adverse reaction to benzos. These are people that are poor methylators. So we do want to do a methylation test. I really do methylation test all the time. Genova offers a fabulous methylation test. It is a blood study, and it really looks at the entire pathway. SAM is overwhelmingly the body's main methyl donor. So think of it as the body's methylation currency, because that's how I look at it. So SAM can donate a methyl group wherever it's needed. There you go, completes the pathway. It becomes SAW, and SAW then breaks down into homocysteine. So when you look at homocysteine, and mine was 16 when I first measured it, thank goodness it's now 8 or 9, it is a marker for cardiovascular disease. Elevated levels are associated with all the things on here: heart disease, bone loss, neurodegenerative conditions, mood disorders, IBD and colon cancer, and of course, breast cancer. So I hope you're getting the idea here. Homocysteine is often used as an indicator of methylation status, and homocysteine must be recycled back into methionine. So homocysteine into higher SAH levels. Elevated SAH, people say, oh, we've never heard of this. This is just looking at things that are research. It has no practical application. That's not true. Here, SAW is a more sensitive indicator of cardiovascular disease than measuring homocysteine itself. So a chronic elevation of homocysteine results in a parallel increase in intracellular or plasma SAH, which is a more sensitive biomarker again for heart disease. So why haven't people been measuring SAH or SAW? Plasma concentrations are right there for you. You do need specialized technology to accurately measure SAM to SAW. So the ratio is on the methylation test. SAM is the body's main methyl donor. SAW is a functional marker for poor recycling. So look at the ratios between them. This is also called the methylation index. So the SAM to SAW ratio is believed to be a good indicator of cellular methylation capacity. SAM tends to be under more homeostatic control. So if you're running low on cash, you will withdraw money from other sources. And that's exactly what happens in the methylation pathway. You'll get a stealing. There's fluctuations that tend to be more due to relative SAH concentrations. So when you look at finishing the cycle, homocysteine must be converted, or else it will lead to a buildup of SAH. The main way to recycle SAM is by turning homocysteine back into methionine. What does that require? It requires activated 5-methotetrahydrofolate and activated B12 or methylcobalamin. Can you over-methylate a patient? Yes, and this is another clinical pearl for today. Overmethylation or excessive is generally associated with oversaturation of methyl-related byproducts, including monoamines, serotonin, norepinephrine, and dopamine. Abnormally high concentrations of monoamines impair cognition, motivation, libido, cause weight gain, and increase the risk of some cancers. So what are signs and symptoms of overmethylation? Only 50% of the world's population have a methylation problem. The other 50% don't. And I see a lot of practitioners just giving methylated vitamins to everybody. Please do not, because then the patient can have anxiety and depression, panic attacks. There's an increase in ADHD, sleep disorders, histamine intolerance or low histamine levels, behavioral disorders, restlessness, sensitivity to environmental toxins, high energy, high creativity, schizophrenia, food and chemical sensitivities, antihistamine intolerance, absence of seasonal allergies, rapid speech, low libido, tendency to be overweight, restless leg syndrome, pacing, improvement with benzos, but that's not the route you want to go down. They do tend to have adverse reactions to SSRIs. They may be self-mutilators. They have a higher rate of tinnitus, hirsutism, adverse reaction to SAMe. They do tend to be more musical. They may have some copper overload. They may have estrogen intolerance and artistic ability. So these are the people that tend to be over methylated. Does this really exist? Yes. So common clinical intervention, take the patient off of methylated vitamins if you have them on there, is the first one. So stop giving them niacin or niacinamide, glycine, vitamin B6, folic acid, DMAE, choline can be helpful. Now remember, we don't give carnitine or choline as a supplement to people if they have high TMAO levels. That's a blood study that can be done at any major lab. Those are people that also should not eat red meat, and those are people that should not have egg yolks. It's about 1% of the world's population. For overmethylation, manganese and zinc and vitamin B12 can also be helpful. And you can see here on the pathway where it works. That's what I love about this test. I just love the pictures because it makes it so much easier to explain the science to people. So what are you looking for? Low homocysteine. The patient's homocysteines too, they're overmethylated. If they have a high SAM-to-SAL ratio, a high sarcosine may be an issue. So there's many articles to support that higher levels of SAM are associated with higher BMI, higher protein intake, higher caloric intake, being overweight or obese. Is metabolic syndrome an overmethylation disorder? Certainly interesting to look at. So the methylation panel, again, is wonderful to look at because there's two sides of it you can see. On the left side is methylation, on the right side is transsulfuration. So the methylation pathway goes into transsulfuration, which on one side is energy production, and on the other side is the ability to detoxify, looking at glutathione, etc. In the middle, you can see you can do an add-on. You can do genetic polymorphisms and actually see, is someone inheriting this gene? So you can get the different SNPs. It's wonderful. So I love having these three pillars to help my patients. And then at the bottom, you can see the methylation status by the SAM-to-SAL ratio, the methylation balance, and the methylation to sulfuration balance as well. On the add-on, there's looking at genetic polymorphisms. There's 10 of them that you can look at. And again, you can see those ratios. So when you look at the SAM-to-SAL ratio, SAM is the body's main methylating donor. SAW is a functional marker for pore recycling. So important that Baird saying this again to look at this ratio. So when you look at the methylation balance, this is really a very novel way to look at things, to see if the patient's overmethylated, undermethylated. You can look at 8 different markers, 4 markers with a methyl group, and 4 markers. You can see at the bottom here, the methylated metabolites, SAM, methionine, betaine, and serine. The unmethylated are listed there for you as well. And this ratio is unique to this test. So Genova is the only company that provides this ratio. So when you look at the MET to sulf ratio, there's 8 different biomarkers. Methylation metabolites of SAM, SAW, methionine, and homocysteine, and then the transsulfuration metabolites are listed there as well. And you can see at the very end, glutathione. And again, this ratio is also unique to Genova's methylation test. So in summary, when you look at the ratios, the SAM-to-SAW ratio is the most severe alteration of methylation balance. When you look at methyl balance ratio, you may be able to detect methylation imbalances earlier than you could otherwise. It may indicate the need for vitamin B12, folate, choline, or betaine. And then the met to self ratio looks at the balance between two independent pathways and may indicate the need for vitamin B6, magnesium, and antioxidant support. So in summary, as you've seen, there's so many risk factors for breast cancer. The good news is that many of these can be mitigated. Testing is here to help patients decrease their risk of developing breast cancer or reoccurrence, as well as you can have a personalized approach to help the patient achieve optimal health. A motto to live by: life is not about how to survive the storm, but how to dance in the rain. Thank you.
That was wonderful. Thank you so much. I have to say, my family history is kind of set up very similar to yours, Dr. Smith. Everybody on my dad's side of the family has had some type of a hormonal related cancer. So this is, extremely valuable information. And I have to say, probably one of the most common questions that we actually received was in regard to melatonin. So if melatonin is within normal limits upon testing, do you still give your breast cancer patients supplemental melatonin?
I do, because even if it's normal to start with, let's say someone came in to see us with a stage 4 breast cancer and the melatonin was normal, would I still give them 12 to 20 milligrams of melatonin? I would, and I go back and remeasure in 90 days, and you'll see that melatonin is still normal, because the body has figured out, again, that it's using it for immune building and fighting the cancer as opposed to using it for other functions. So it's interesting. It is not too high, even if you're using big doses, appropriately in patients.
The other question we received regarding melatonin is, can it be preventative for breast cancer or your high-risk breast cancer patient?
That's my question. But again, if you have too much serotonin or too much melatonin, serotonin goes down. And then you have to look at gut health, because 90% of serotonin is made in the gut. So you can broaden your approach at how you would look at that. I always measure melatonin. If someone comes into me on melatonin, I measure it. When I'm measuring their hormones, melatonin is part of really the balance of the other hormones. It affects insulin, thyroid, etc. as well. So I commonly measure melatonin.
Okay. And what is your favorite route of administering melatonin? Because there are sublingual options as well. So what is your preference?
I use just plain orally as a pill. Sublingual may make the test not as accurate. So I don't tend to do a lot of sublingual. I don't tend to have compounded troches, because saliva testing, even of traditional hormones or melatonin, the norms were not.
That's a great point. That's a very great point. We have a few other questions. Well, first of all, I just want to share really quickly with you, there has been a tremendous amount of feedback, fantastic presentations, so clinically useful. So you've received tremendous feedback from the information that you shared, and I definitely echo the same excitement about the presentation you provided. But I have a personal question. It's in regards to those patients who may have an elevation in beta-glucuronidase upon stool testing, which, as you are aware, it really influences the recirculation of our hormones. So somebody who's in our position where we have that higher risk factor of breast cancer and a higher beta-glucuronidase, how would you approach estrogen metabolism? Would you approach it the same as if they don't have the elevated beta-glucuronidase, or just a little bit different?
Well, I actually look at a broader approach. So I am going to look at a 24-hour urine and see what's going on, so I can see all the pathways. I do give calcium deglucarate to those patients. There's a couple studies showing that milk thistle may also be beneficial for those patients. So I look, 70% of the immune system's in the gut. So you've got to look at the gut. It's not just about looking at what happens with the breakdown of the hormones, but you have to look at that. So it's a really good point. If it's there, I start calcium deglucarate.
So in terms of, I think it's very interesting. One person made a comment that her client told her that her doctors relate to her that cancer has nothing to do with the diet. Okay. But I think you've totally busted that myth today. You've talked about alcohol, you talked about sugar consumption and different things like that. So, and histamine. So I think you've totally already just debunked that with the literature that you presented. But I guess the next question we have is for a patient that might have risk factors for breast cancer, whether it is, they've had no children or they've had children at earlier ages or they have a strong family history. In terms of functional medicine approach, where would you start?
That's a really great question. And to give you an interesting idea, the first talk I ever gave in the hospital, and this has been many years ago, was actually to the cancer center. And I was talking about breast cancer. So this, how long ago? This was almost 29 years ago that I gave this talk, and I was startled. I could hardly give my talk. And, having been an ER doc in a level 1 trauma center, not much startles me. But as I was speaking, they were feeding all these patients with breast cancer donuts. And I could not believe it. So you're right, people just don't get it. So you have to meet the patient where they are. If someone's an alcoholic, are they gonna abruptly stop their alcohol? Not unless you send them for actual treatment. And I sit down and I explain to them that, you inherit a gene for alcoholism. So honestly, it's a personalized approach. So I probably, if it's hormonally related breast cancer, I do start with hormones, which I measure thyroid at the same time, insulin at the same time because of blood sugar, cortisol, all of those things along with the female hormones all at one time because it is a hormonal symphony. So usually I start there. It's not 100% of the time, but most of the time.
I have to say personally, I love that you said insulin because I think sometimes a lot of clinicians, they'll focus so much on the HbA1c or they'll focus so much on the fasting glucose, not realizing that the insulin is actually the hormone level that will actually change prior to all of that. So I love that because I preach that. I'm like, measure the insulin. So I actually love that you did bring that up today. And I guess that same approach that you take for somebody who has a risk factor would actually be the same approach that you would take for a patient that already is diagnosed with cancer. It's more of this individualized approach to what they have going on.
It is because, again, if they live on sugar all day long, they're not going to stop it. So I try and say, hey, how about if we cut it down in half? Let's start there. And we'll work on all these other things that are going to be easier for you to do. My personal one that was the hardest for me in all this was exercise. I just don't get the high that people get from exercising. I don't know, my epinephrine or norepinephrine doesn't go up. But why do I exercise? Maintain memory, prevention of breast cancer. So, everybody has something different that is their hardest thing. So again, it is a personalized approach. That's what I love about functional medicine and anti-aging.
Understand. I think my poison, I would have to say, is definitely sugar, especially coming around these holiday times. And I think during the pandemic, a lot of people have increased their alcohol intake, which might be their new poison as well. And so, the beer liquor industries are thriving. Okay. But no, I understand. I think that was a great presentation. And truly, I love how you really preach personalized medicine and meet the patient where they're at, because a lot of times clinicians will have our dream list of everything you'll do. And that really isn't always ideal or reasonable for that patient where they are in their lives at that time. So unfortunately, I have to be the bearer of bad news. The time is 1 o'clock. So we have reached the end of our wonderful question and answer session. So Dr. Smith, again, thank you so much. It was just I probably said it 50 times, but seriously, it was really great. So just for everybody, if you'd like to visit our website, www.gdx.net, you can also contact client services for more information about testing, about ordering testing. You can definitely schedule appointments with our medical education specialists to help navigate the different options that you have available for you. We also like to encourage you all to register for our upcoming webinars. Lastly, if you have not already checked out the Genova's podcast, the Lab Report, which focuses on like functional and integrative medicine, specialty laboratory testing, natural therapeutics, the host with Dr. Patty and Michael, and assorted guests, I would suggest that you go ahead, check it out, register, subscribe, whatever people do nowadays.